Good evening, everyone, and welcome to our UMiami Health Talk titled Managing Cardiovascular Care in Older Adults. I'm health journalist Ileana Bravo, and I will be your moderator this evening. I know many of you are still coming on to our Zoom call, and we will continue to wait as everyone joins us. But just to give you a little bit of format explanations and what it's all about tonight. The talk, of course, is presented by UHealth Virtual Clinics, and the expert providers are here for you. They're ready to provide clinics inside their clinics, of course, and virtually. They're coming to you wherever you are, wherever you need to be taken care of. We invite you to learn more about the measures, of course, that we have in place to keep you safe, as well as your appointment scheduling options. And you should go to umiamihealth.org to learn what those are. Tonight, we're pleased to have as our expert provider and guest is Dr. Murry Drescher, a cardiologist with the University of Miami Health System. During Dr. Drescher's presentation, of course, we're going to poll the audience, which is customary for us to sort of get an idea, a demographic, and a profile of who you all are joining us tonight, and therefore we can address all of your questions and concerns. Don't worry, it's anonymous. You will not be identified. We also have a question and answer session at the end of Dr. Drescher's presentation, and you can see it at the little Q&A box at the bottom of your Zoom screen. Go ahead and locate that now. It has two thought bubbles. It says Q&A, and that's where you will enter your questions, and then we will look at them and tee them up for Dr. Drescher to answer at the conclusion of his presentation. So we'll do our best to get to all of them. There are many of you on here tonight, so we're thrilled to have you and welcome you. Now let's introduce Dr. Murry Drescher, who is a staff physician within the Division of Cardiovascular Services at the University of Miami Health System. He's a fellow of the American College of Cardiology, double board certified in internal medicine and cardiology, and he sees patients in his Plantation and in Boca Raton clinics. Dr. Drescher specializes in general cardiology and cardiology care for older adults. We welcome you tonight, Dr. Drescher. Take it away.
Thank you so much for those kind words. So basically, and thank you all for coming tonight. Hopefully I will make this interesting for you all. This is a very important topic. And first I'd like to bring up why. Because really, patients over 65 who are defined as geriatric make up 60% of cardiology patients. And interestingly enough, when clinical trials are designed for medications and other treatments for cardiovascular disease, often this group is excluded. So most of the time, what we know about treating older patients may come from registries where people report at hospitals how patients are doing from various treatments, as opposed to a randomized trial. Next slide, please.
So that's perfect, because we're going to start with the first poll question, which I think will give us in a nutshell who our audience is. So there it is on the screen. Do you think of yourself as geriatric? The hundreds of you who are on this call with us tonight, there are your multiple choice answers. Are you really asking me this? Is the first choice. Second is, I'm of an age that qualifies, but I'm still young at heart. Or no, but I'm the caregiver for someone who is. So there's the question on your screen. You are to tick the little box of the selection of the response that you want. Do you think of yourself as being geriatric? First response, are you really asking me this? Secondly, I'm of an age that qualifies, but still young at heart. And the third one is no, I'm the caregiver of someone who is. So let's see, Dr. Drescher, what our responses are to that first poll question. There you go. Young at heart.
Young at heart. Okay. So let's move on. I did want to add now, although we do define geriatric patients as over 65 in the past, and basically in heart disease, we're sort of, since a lot of people are working past 65, they're not retired, with advances in what we've done for medicine, we sort of changed the definition with cardiology, and we sort of look at the elderly as 75 to 85 and the very elderly at over 85. I'm not sure But actually, really, age is not that important with cardiac disease. It really depends on how healthy the patients are. So I'm going to talk about age and cardiovascular health. And it's very interesting. As you get older, your blood pressure increases, as does your cholesterol, leading to an increased risk of heart attack and stroke. And the incidence of atrial fibrillation goes up also, and that also increases your risk for stroke. And then you tend to have a lot of comorbid conditions, and you take more than one medication, and the changes in the metabolism of these medications can also occur, which could mean you end up taking too much or too little of the medication if you continue on the same dose. Next slide, please. So I'm going to have a little definitions here. Systolic pressure is the top number when we measure a pressure. And the bottom number is the diastolic pressure. So we give you two numbers. And basically when the heart pumps, it is pumping the blood out, it increases the pressure, and that's the systolic pressure. And when the heart relaxes and lets more blood into it to be pumped next, that is what the diastolic pressure is. Next slide, please. So as people age, their arteries stiffen, and patients often get only the top number, the systolic blood pressure, being elevated. And we used to think that was something normal, but interestingly enough, we also realized that it was normal for people to get heart attacks and strokes as they get older. And we even had a formula about what your normal pressure would be by your age. But later studies were finally done, and they realized that if you treated the blood pressure, both systolic and diastolic, in the older patients, they had decreased heart attacks and strokes and lived longer. And which is one of the main reasons why the average life expectancy is in this country now is 78, as opposed to in the 60s when we started treating this. So next slide, please. Poll question.
There we go. So here's the second poll question of the evening. Are you currently taking medication for hypertension? Yes or no? Tick the box of yes or no on your screen that you're seeing right now if you're currently taking medication for hypertension. We'll give everyone a moment to catch on there. And remember your Q&A screen at the bottom of the Zoom screen so that you can ask us questions so Dr. Drescher can get to them during this. And here are the results coming up. And of course, 64% Dr. Drescher say yes, they are.
Yes, I see. That's very close to reality out there. So how do we treat blood pressure in older patients? The same way we do in younger patients. We use more older patients have isolated systolic high blood pressure. The top number is elevated while the bottom number is not. But we do not, when we treat the systolic heart blood pressure, we don't really end up lowering the diastolic pressure that much. Older patients tend to require more medications to treat high blood pressure, and it is not uncommon to combine 3 or 4 medications to control the blood pressure in older patients. And the side effects from blood pressure medicines often increase when the dosages increase. So sometimes we use multiple medicines because we can use them at lower dosages and have less side effects from each of the individual medications. Next slide, please. So the goal of blood pressure treatment in older adults is really the same as in the general population. We like to see the systolic blood pressure to be 130 or less. The diastolic pressure should be 80 or less. And there's usually no hurry to really lower the blood pressure quickly, because unless you're having acute symptoms that you need to be hospitalized for, like having a stroke or intractable headache or visual problems that the blood pressure is causing, most of the time high blood pressure doesn't give you any symptoms. So you have plenty of time to lower them before something bad happens. And if you lower your pressure too quickly, sometimes you can feel dizzy. You're not used to that lower blood pressure. You can have side effects. So there's no great rush to completely control blood pressure at once, and there's plenty of time to treat it. Next slide, please. So in my practice, and I think this is the ideal way to treat high blood pressure patients, I find a patient with high blood pressure or pressure that's not controlled. I will add a medication, and then I will see that patient in 2 to 4 weeks to see if it's working. And it really, this is very important. I can't tell you how many times I see patients that are started on a medication and then they're seen 6 months later and it doesn't work. So you've given that patient another 6 months of no treatment, and that's a little bit long in my opinion. So you really need, it's not enough to be on a medication. It's only enough if the medication actually controls the blood pressure. Next slide, please. So some medications are very interesting. They cause side effects in older patients more than in younger patients. The tolerance of a medication can change as the same patient who's been taking the medication for years, they may, when they get older, get side effects. One of those medications that often does that is a calcium channel blocker called amlodipine, which is usually very well tolerated in younger patients. But once you start hitting over 65, it can cause your feet to swell. And then they send you to the cardiologist thinking you might have heart failure, and I come and see you. The first thing I do when I see a patient for any complaint is I look through what medications they're on and see if any of the medications can cause the symptoms that the patients are having. And I very frequently find out patients who are started a medication at 50 and now they're 70 and they're complaining of their feet swelling, and there's nothing wrong with their heart. It's just a side effect of the medication that occurs more commonly in the elderly. And this one I also like. There are some of the older prostate medicines that were also used as blood pressure medicine. And those medicines can actually cause you to faint as you get older. When you're younger, it rarely does that. So I've had multiple patients come in to see me for fainting, because because sometimes fainting comes from your heart going too slow, from your blood pressure being low, from your heart going too fast. So everybody that faints ends up seeing a cardiologist. The first thing I do is I look at your medications, and I see patients who are on these medications for years and never borrowed them. Nobody could figure out why they were passing out, and they've had a complete workup. And I just changed their prostate medicine, and they're no longer fainting. So it's very important to know that just because you tolerate a pressure or any medicine as a younger person, when you get older, you might not tolerate it. Next slide, please. So now we're going to talk about high cholesterol. High cholesterol is a very important topic. Lowering cholesterol has led to a huge decrease in the amount of heart attacks and strokes and cardiac death since they've been discovered and invented. So basically, high cholesterol in older people should be treated if the patient has vascular disease, which I would define as blockages in their coronary arteries, their carotids, their peripheral arteries in their legs. Anywhere where vascular disease is being caused by plaque, which starts out being made up of cholesterol plaque. And in older patients without vascular disease, they're really, in patients over 75, there's not a lot of data if they can't demonstrate that they have vascular disease that reducing the cholesterol will help any. And included in vascular disease would be a patient with diabetes and an additional risk factor for having vascular disease. Of course, that's how they designed the studies to look at these things. Next slide, please. So we use the same medicines in older adults as we use in younger patients. The mainstay of medicines we use are statins, and you've probably heard of them. There's atorvastatin, Lipitor, rosuvastatin, which is Crestor. Some of the older ones, which are not quite as potent. The most common side effect of statins is muscle aches, which can be difficult to distinguish from pains that occur more frequently in older people. So a lot of times we can't tell whether you're having the pains because you have something else or whether it's from there. But if you cannot take a statin, there's been a new medication that's been out in the last 4 or 5 years. And there's two different ones that work in a similar way, and they're injectable, and you take them either every 2 weeks or every month. And they lower your cholesterol as well, if not better, and you don't have the muscle problems with those medications. So if you have high cholesterol, it's not that it's a lot easier to get these medications. For a while, they were very hard to get, but now they're cheaper. They're not cheap, but they're cheaper. And now more insurance companies are covering them. So basically, most of the time, your family doctor or your internist will not prescribe those because you really need a system in your to get it approved through the insurance companies. And so you have to be used to prescribing them because to know how to get them. Otherwise, it's very cumbersome, and most people in primary care don't want to do that. Next slide, please.
Okay, so here's the question now, since we're talking about all these medications. Have you ever experienced chest pain or had a heart attack? It's yes or no, or unsure if you're not sure, but have you ever experienced chest pain or experienced a heart attack? You see the box on your screen for all you participants out there, and please assist us in helping this poll question so that Dr. Drescher can get an idea. Well, that's good.
Yes. Okay, so let's move on. So when we talk about heart disease and coronary disease, and we talk about either stable or unstable coronary disease. So what is stable coronary disease? These are people who have coronary artery disease, which are blockages of the coronary arteries that supply blood to the heart muscle, but are not having unstable symptoms in that can lead to a heart attack or death. So basically, there are a lot of people with coronary disease who get angina with exertion. It goes away with rest. It's stable. Medications help it so they don't have it that often. And that's considered stable coronary artery disease. There's no clot in there. There's no ruptured plaque in there. It's just a narrowing that came from the plaque growing over the years, usually. Stable patients may have chest pain with exertion, but it does go away with rest or with nitroglycerin. Next slide, please. So unstable disease occurs when there is a ruptured plaque in the coronary artery. The plaques are made out of cholesterol and other cells, and the shoulder of the plaque gets weak and it can rupture, and then the plaque gets exposed to blood, and the inside of the plaque causes blood to clot. And but in stable coronary disease, treatment depends on whether symptoms can be controlled with medication, and also whether there is evidence of high risk on a patient's stress test or echocardiogram, which is a sound-wave picture of the heart. So treatment for stable coronary artery disease is similar in older people as to the rest of the population. Next slide, please. So if medical treatments fail to sufficiently reduce symptoms in a patient with stable coronary disease, there are options for percutaneous, which means you go through the skin, you make a little incision in the skin to get to the artery. It's not considered surgery, and you can do an angioplasty and place a stent in the blocked artery, or coronary artery bypass surgery is also available. Now, due to comorbidities, often in older adults, especially those who are over 85, the risk of surgery increases with age, usually making a percutaneous approach safer in most cases. And you end up having, sometimes if in a younger patient, we would ordinarily do bypass surgery. In an older patient, the surgeons will turn down the bypass surgery as being too risky. So we basically have a group meeting between the surgeons and the cardiologist as to what the best approach in each patient is. Patients with stable coronary artery disease need aggressive risk management, including cholesterol lowering, controlling blood pressure, lifestyle modification, including diet and exercise. And I did leave out of my speech here is smoking cessation, cigarette smoking cessation is very important. Next slide, please. So what is a heart attack? As I said, a heart attack is otherwise known as a myocardial infarction. It's caused by a plaque that is ruptured in a coronary artery to form a clot that either completely or almost completely blocks the artery. And because it's an acute emergency, and often is life-threatening, we actually treat this the same way in older patients as in younger patients usually, unless somebody is terminal, has a terminal disease, doesn't want it. But that's how we approach it, both for older patients and younger patients. Next slide, please. So if a clot completely blocks the artery, the heart muscle begins to die because it's not getting any blood. And if it doesn't get reestablished blood supply within 6 hours, all the muscle supplied that artery can become irretrievably dead. And you can have a lot of heart damage, you can die, you can have arrhythmia from it, causing sudden death. And basically, this is an emergency. And if you're having chest pain and you don't know what it's from, especially if it's associated with shortness of breath and sweating, is very, and nausea and vomiting, is very important to call 911. You should never drive yourself to the hospital if you think you're having a heart attack, because if you're driving and you have an arrhythmia and have a cardiac arrest, you'll crash your car, you'll be dead before anybody gets there. In addition, you shouldn't have somebody else drive you there, because if you're sitting next to that person and you're having a heart attack, he has to pull to the side of the road, pull you out of there, then call 911, whatever. Somebody has to start CPR right away. And if they don't, then you have irreversible brain damage. So I cannot re-emphasize how important it is for anyone who thinks they're having a heart attack to call 911. And if you're not having one, they'll say, no, everything's fine, and they'll leave. But you can't take that chance, especially people with risk factors. But even people, 50% of heart disease, this is an old statistic, by the way, it hasn't changed all the years. 50% of people with coronary artery disease present their disease with a heart attack. Half of those die before they ever get to the hospital. That's a terrible statistic, and it's only because, and the reason it's that high of people dying is that people don't call 911. I'm having indigestion. Oh, it can't be me. They're in denial. I don't want to know about it. Don't do that. You need to really go about and get that treated. Next slide, please. So now I'm going to move on to congestive heart failure. Congestive heart failure is really defined as a condition where the heart is either too weak or too stiff to pump blood efficiently, which causes the pressures to rise in the heart. It gets backed up into the lungs, and then you end up having water going into the lungs, which causes shortness of breath. Okay, so that's what congestive heart failure is. The most common cause of congestive heart failure is heart damage caused by heart attacks, but it can also be caused by hypertension, coronary disease without heart attacks, diabetes, and other things. So advances in heart attack treatments, because we're saving a lot more people, have led to more people living longer with heart damage, and that has resulted in a huge increase in the amount of heart failure cases that we have. Treatment of heart failure is the same for older patients as it is for younger patients, resulting in decreased death and improved quality of life. And these treatments include medical treatments, device treatments, heart transplants in younger patients. Usually older patients, because of the problems in doing that, and the complexity, they rarely do heart transplants in patients over 65. Next slide, please. Now I want to talk about atrial fibrillation. Atrial fibrillation is an irregular heart rhythm where the atria in the heart, which pumps into the ventricles, which then pumps the blood into your systemic circulation through the aorta and into the lungs to get oxygen. Well, the atria end up, instead of pumping to prime the left ventricle pump, it goes into this irregular rhythm where it doesn't pump. The atria tends to get dilated, and when the atrium do not pump, the blood pools inside it and causes blood clots, and those blood clots can go into the brain and cause stroke. They actually can go everywhere. They can go into your legs and cause you to clot off a leg, which you can then you have to fix and take the clot out. So basically, the incidence of atrial fibrillation increases with age. It is very common in older adults. The problem with atrial fibrillation is that there are treatments for it, but it requires being treated with anticoagulation, and we have risk scores for that, but it is definitely something that's a big problem in the elderly. Next slide, please. So treatment of atrial fibrillation focuses on controlling the rapid heart rate with the goal of restoring a normal rhythm and giving anticoagulation to prevent clot formation and to treat clot formation and prevent stroke. In the elderly, there's increased risk of bleeding, and very frail patients may not be able to take anticoagulation. I did want to mention UHealth offers leading edge therapies for the management of, and control of atrial fibrillation. We do have treatments where they actually use a microwave catheter that can ablate the atrial fibrillation. But in general, even if they ablate it, it doesn't necessarily work 100% of the time. And patients who have atrial fibrillation mostly need blood thinners. And if you're overset, and we have a scoring system for that, and you get 1 point in the scoring system for being older than 65, 2 points if you're older than 75. And so you basically, if you're older, you automatically need blood thinners. Next slide, please. So we're going to talk about some valvular heart disease. Aortic stenosis is what I'm going to talk about, although the other common one would be mitral regurgitation, but aortic stenosis is much more common. And the aortic valve is the valve that goes between the left ventricle to the aorta, which carries the blood to the rest of the body, your brain, your legs, your gut. And basically, as you get older, calcium deposits on that valve prevents it from opening up and the blood can't get out, which can lead to heart failure and death. It is often, there is aortic stenosis that comes from congenital heart disease, which occurs in patients who are younger. But in general, aortic stenosis becomes much more frequent as you get older than 65. It becomes progressive, and eventually something may need to be done about it. Aortic stenosis can now be safely treated even in elderly patients with a bioprosthetic. That means the valve is made with tissue from animals that can be implanted in either an artery in the leg or via minimally invasive surgery. So basically, it used to be when you were really old, we could not open your chest and do that because it's just too risky. But now we can treat patients into their 90s who are otherwise well and can tolerate this. We go up through the leg and leave it in there, and it's without surgery, and go home the next day if everything goes well. So this is a breakthrough. Initially, we only used it in people who were not, this new breakthrough, who were not candidates for surgery, but they've actually showed that this procedure is actually better than surgery in younger patients. So we tend to use this in everybody now who are candidates for this kind of procedure. At the University of Miami, we pioneered this procedure it's called transaortic valvular replacement, TAVR. And they do it very well, and they have more cases than anybody else in South Florida. People down at the University of Miami, they have a valve clinic where they evaluate valves. Next slide, please.
Actually, it's going to be our final poll question for the evening, Dr. Drescher. Okay. And since we're talking about so many medications, here's the question. How many medications do you take?
Before we go into that question, I did want to add that I did not put it in my slide, but sometimes people have very leaky mitral valves and you might need surgery. And a lot of times the elderly couldn't get that, but now we can fix that through the percutaneously as well in a lot of patients. So now we'll go on with the question.
Yeah, so how many medications do all of you who are out there listening and watching tonight take on a daily basis? First choice is none, 1 to 3, 4 to 6, or more than 6 medications. And I probably won't be surprised to hear that people are on a lot of medications. And also, by the way, you're all giving us a lot of excellent questions that you're presenting for Dr. Drescher to answer, and we'll do our best. So we are going to hang in there as long as we can to answer them all. What do you think, Dr. Drescher? Look at the results.
And it's a lot of patients are taking a lot of medications. As I said, as you get older, you have more conditions that need to be treated. The good news is my patients always ask me, Doc, is this going to interfere with my other medications? And I tell everybody, don't worry, the medicines know where to go. If you take them all together, they all go to where they need to go. They know where to go, and usually there's not a problem. There are occasional problems, but for the most part, luckily, you can take all the medicines and you don't have to worry about that. So now I want to talk about special considerations for treatment of older adults. Many older heart patients have other coexisting illnesses that complicate their treatment. polypharmacy, which is defined as needing 5 or more medications daily because of multiple illnesses. Many older patients need more than 5 medications. Next slide, please. As the number of medications increases, so does the risk of side effects and interactions. The physician who prescribes them must be aware of them. Fortunately, diseases like Parkinson's disease, diabetes, and dementia, which are more common in the elderly, require medications, but usually cardiovascular medications do not interfere with diseases given in Parkinson's disease or dementia. Next slide, please. Especially in very elderly patients over 85 years old, the quality of life issues become more important. Patients with severe dementia may benefit more from comfort care management than aggressive treatment. The decision as to how aggressively a patient should be treated involves an extensive conversation with the patient and the patient's family before care is instituted or continued. Next slide, please. Age alone is not usually a reason to avoid aggressive treatment, as many very elderly patients are fully functional and have a good quality of life. In the end, in every patient, it is up to the physicians to outline options and risk benefits of a treatment plan, and up to the patient and their family and/or surrogate to make a final decision as to care. I don't think there's any more slides, but there you go.
Okay, that's great. Thank you so much, Dr. Drescher. Incredibly packed with information. So let's get to the Q&A, because I know people are desperate to hear some of these things. So here's a question that I know you addressed earlier about inflammation of the feet. So could inflammation of the feet be a cardiac condition?
Inflammation of the feet can come from many things. So say if you have blockages to the artery in your legs, sometimes you can get wounds there that won't heal, and that causes inflammation. If you have congestive heart failure, where the fluid goes into the lungs, it also puts pressure backwards into the veins going from your legs, and you can have swelling in your feet, and if it gets very swollen, the feet can also be inflamed. So there's a couple of things. So that those are the main things that come from the heart. And as I say, swelling in itself does not necessarily cause inflammation unless it really stretches the skin, and then you can get superimposed infection because you don't have good circulation because there's so much water in there. Not because there's not a blood going down there, but you're not supposed to go through all those layers of water to circulate blood. So it can, but in general, unless there's an infection or something else going on, or it doesn't really cause inflammation.
Okay. Again, we're dealing with an aging population here, so there are a lot of questions on dementia in cardiovascular care.
Okay.
So perhaps we can lump a bunch of these together, Dr. Drescher, so you can address them at once. One of them asks, her father's 84 years old, has dementia, and is going to have cardiovascular surgery. Is that safe? And then there are other questions on, can a patient experience slowed progression of dementia if he or she complies with his or her cardiac medication? What is the relationship between high blood pressure and dementia? I've thrown a lot at you, but
all right,
take it and run with it.
If you have coronary artery bypass surgery and you have dementia, it's possible it could make the dementia worse. That's clear, especially being on bypass pump. They can do heart surgery off the pump, but it's harder to do in older patients who have dementia. So that's one of the reasons in those patients, sometimes they prefer to do angioplasty and stenting, which does not increase your risk of any dementia at all. Okay, that's number one. The other issues is cardiac drugs do not, despite the internet, cause dementia. Okay. There was talk whether the statins could cause dementia. There's probably nothing that's had more data in getting approved than all these statin drugs, and there's absolutely no evidence that statins cause dementia, really. So statins do not cause dementia. As for high blood pressure, the kind of dementia caused by high blood pressure that is untreated are small little strokes, unlike Alzheimer's, which is caused by plaques. that are formed for reasons we do not know yet. But so what happens is if you have untreated high blood pressure for many years, the artery is constricting the brain and you have these tiny little strokes. And they're called so they call that like vascular dementia. And so in that condition, you can have dementia from that. But the most common cause of dementia we have really is, and you can also have dementia if you have strokes, regular strokes, as opposed to that kind of stroke which is also contributed to by high blood pressure. But in general, the most common cause of dementia is Alzheimer's dementia.
Okay, so let's move on to a lifestyle question here. Very interesting. Is very vigorous exercise that raises the pulse to 150 beats per minute for 30 to 40 minutes okay for someone in your 70s?
Well, when we do stress tests, we push people, as you get older, your heart rate tends to go up less. So when you get up into your 70s, we calculate a maximum predicted heart rate, which has been shown to occur, of how much your blood pressure, your heart rate can go up to according to age. So when you're really young, your heart rate can go up to way high. As you get older, your heart rate can't go that high no matter how much you exercise. Okay, and the way we calculate that maximum heart rate is we take your age and you subtract it from the number 220. And so, which means if you're 70, your maximum heart rate is 150. So, and it would be very high. I mean, there are exceptions, of course, and it's in general. But in general, what we advise people is to basically exercise to 85% of the maximum predicted heart rate if they want to. The good news is any exercise is good. Walking is good. You don't really have to push yourself in doing that. It's definitely safe to do it up to 85% if you have no other reason not to exercise, like unstable heart conditions, etc., or you're getting chest pain with exercise and then you have to fix something. So in general, we tell people to exercise. It's safe to do so. We don't necessarily advise you to do so if you just walk briskly every day where it won't go up that high, or do other kinds of exercise that's not that strenuous. Just doing the exercise for a half hour 3 times a week really decreases cardiac risk.
Yeah. I, like you, took it as good news that at least they're exercising. So it was a positive. The headline was. Here's a question from Barbara. What are the protocols to address a decrease in heart ejection fraction due to Herceptin chemotherapy from breast cancer treatment? Very specific question.
It's good you asked that question to me because I'm now the resident cardiologist at the Sylvester Plantation Cancer Center. So they send me all those patients. Okay, and basically there are 2 common used cancer therapies that can affect the heart. One is adriamycin or doxorubicin. That's very similar to that medicine, which is older. And then there are the newer ones that are immunoglobulin targeted antibody medications. And Herceptin is one of those. And Herceptin has been found, especially if you use it together with the other one, to severely to lower your ejection fraction in a lot of people. So we can, and they're both used for breast cancer, by the way. So what happens is that you can use both of them, but you don't use them together. You can use them sequentially. With Herceptin, if you have decreased ejection fraction with adriamycin, it usually doesn't go away. So what we do with adriamycin is we give you a few chemos, we look at your echo and see if there's any decrease in function. And then we'll give it again. And if we start to see a decrease in function, then we don't give it to you anymore. With Herceptin, it can decrease your function. So we give you a trial of it, and then we will check another echo to see if it's had any effect. And again, if the ejection fraction diminishes, we stop. But the good news about Herceptin is you have a little more leeway because it's usually reversible. So if you stop the medicine and you put patients on heart failure medications, the heart tends to get better. So that's really the answer about Herceptin. And as I said, the main 2 drugs I'm asked about. There's some other ones that are sort of esoteric that may or may not, but it happens much less frequently, and they're not really monitoring them that often.
Okay.
Is that a
Um,
good question?
I think you did great. Let's talk about this whole idea of reversing the effects of heart disease. Someone asked the question about, are there medications such as Visipa and so forth that can reverse heart disease? And you were referring to the injectable ones that I believe are supposed to lower cholesterol,
Right,
plaque, calcium, which is Repatha, for instance,
right.
which I'm
Well,
aware
actually,
of.
it doesn't look calcium. What happens is when you get cholesterol in your arteries and it's been there a long time, okay, and it's irritated and it stimulates the body to calcify the plaques. Now, so we can't, once the calcium is there, you can't get rid of it. But the good news is that the calcium is not really the problem. It's just a symbol of the problem. It lets us know when you do a CT scan to see your calcium score, to see if you're making coronary disease. The place where the calcium is does not necessarily have any blockage there. And remember, your coronary arteries are basically tubes. It's plumbing. And we don't want to clog up the pipes. So if the pipes don't look so pretty, but they're still working, it's not such a big problem. By lowering the cholesterol, you prevent more calcium from forming, and you shrink the plaques that are already there so that they don't rupture and cause a heart attack or worse blockage there. So basically, yes, the medicines that we know will do that are statins, usually high doses, and the more potent statins, and Repatha, which is a little more potent and it can lower your bad cholesterol by over 50%, which is,
But the Repatha can do that with the cholesterol, but not eliminate or dissolve plaque. These are the questions people are asking.
It shrinks the plaque and prevents them from rupturing, but it does not get rid of calcium. The calcium, once you have it, is from older plaque that calcifies. So you won't get, your calcium scores won't go down by being treated. It just hopefully won't go up. And you won't have any heart attack from it. And as for the question of Visipa, Visipa is a purified fish oil of eicosapentaenoic acid. Fish oil consists of multiple omega-3, which you buy over the counter. So this one is only one of that kind, and it's the only one. It came out recently a few years ago. And no, it's been out, but they did a trial on it, and it's used for treating triglycerides, by the way, not for cholesterol. And it's the only drug to treat triglycerides, including the other kind of fish oils, that's been shown in patients who have coronary disease and their triglycerides are over 150, you decrease your risk of heart attack, death, and stroke by 20%, on top of your statin and all your other medicines. You have to still be taking your statin and everything. So they took a bunch of people who had coronary disease or diabetes with 2 risk factors, and they added or vascular disease, and they added the Visipa to their statin that they were already taking, and they followed them out for a few years, and they found out the FDA approved it because they showed that 20% less people in the group that were taking it had heart attacks, strokes, and cardiac death. So that's really a newer drug, and it can do that. But the mechanism of doing that, and we're really not quite sure how triglycerides actually cause the plaques, because you don't necessarily find triglycerides inside the plaque. The plaques are really cholesterol. But the data is there, and it's a good drug to take if you're already on a statin and you can't get it. The statins lower your triglycerides too, but sometimes people have really bad triglyceride lowering. The other triglyceride drugs, for example, like fenofibrate, over-the-counter fish oil. There's another one named Lovasa, which is a mixture of 2 different kinds of omega-3s that's purified. Those have not been shown to decrease cardiac events when you lower the triglycerides.
Okay, we're getting slammed with questions, Dr. Drescher. There's so much information out there.
Talk succinct.
You're
To
great.
cover a broad area so that
But
I
it
have
shows us,
possible.
you're so right. It shows us the concerns out there and the population, how vast it is in this particular area. So here's someone who's just basically, what do you mean when you talk about calcium scores? And is there such a thing as your cholesterol getting too low? Things like that.
Well, I'll tell you, a calcium score is a special CT scan where they do a CT scan to detect the calcium in your coronary artery. And depending on the the CT, and they set the settings. This guy named Dr. Agatston developed a score to count the amount of calcium in each of the arteries. And then they compare the amount of calcium, and 0 is the best when you have none. But it's sort of age related. So as you get older, even if you're not really getting coronary disease, you deposit calcium in a lot of different places, sometimes into the coronary. So it's sort of normalized to your age. And if I'll tell you what I use it for. I use it when a patient has no real risk factors, okay, and has high cholesterol, other than that. And they don't want to take cholesterol medicine. And I can't convince them, so I'll do a calcium score. And if there's no calcium, I say, all right, we'll repeat this every once in a while. If you start making calcium, we'll treat your cholesterol. Otherwise, it's not, obviously you're not making plaque. Or I get somebody who doesn't want to take cholesterol medicine for any reason, and even though they have risk factors and they should be taking them, and I would treat them, I will do that to demonstrate to them what's going on, and maybe try to convince them to take the medications. So basically, it's the calcium score is a very useful test, and it does correlate very well with having heart attacks. The calcium scores.
All right, here's a very specific question. I know it almost feels like it's almost very private information they're giving us, but it's all anonymous, of course. But I'm currently taking Eliquis for AFibs. When I turned 65, my cardiologist said I had to increase my dose simply because of my age. And I believe the lower dosage worked. Why should I automatically have to take more just because I turned 65?
I'm going to tell you, I don't know what your cardiologist was doing. I don't know who he is or what he is. But we don't adjust the dose of Eliquis, okay, for atrial fibrillation on the basis of age, okay. We decide whether to use Eliquis at all. For example, we have something called a CHADS-VAS score, which tells us whether to anticoagulate someone with atrial fibrillation. And so it's basically, the C stands for congestive heart failure, H stands for hypertension, A stands for age, D stands for diabetes. You get 1 point for those. S stands for stroke. You get 2 points for that. VASC stands for vascular disease, like coronary disease or vascular disease. You get a point for that. So basically, if you have 0 points or 1 point, you don't really need to be anticoagulated at all. You don't need a blood thinner. If you have 2 points, you need a blood thinner. That's how everybody's treating it now. So giving you a half dose of Eliquis before you're 65, okay, doesn't make any sense, because it's not, the only time we give a half dose of Eliquis is if you have kidney failure, if your creatinine is high, it's 2 out of 3. If your creatinine is high, there's 3 things we look at: age, creatinine, and weight. So if you have 2 of those things, we give you the lower dose. So basically, if you're over 80 and your creatinines are higher than 1.5, we give you the lower dose. If you weigh less than 60 kilos and your creatinine is 1.5, we give you the lower dose. So that's how we just decrease the dose if you have certain kidney issues. It probably really isn't necessary either, because now they're giving 5 milligrams twice a day for people who have no kidney function, renal failure patients. But that's how they designed the study to get this stuff approved. So basically, I think the guy, you might have had a CHADS-VAS score of 1. I'm talking to the patient who asked the question. And he was, and you have a choice. You can treat it if they're 1. So he decided to treat you with a half dose, but there's no data he's doing you any good by doing that. But now that you've turned 65, you got another point. Actually, if you're 75, you get 2 points. So now that you're over 65, you get a point. So if you had high blood pressure and that was your only point before, or you had diabetes and that was the only point before, then you wouldn't need it. But then you turn 65, and now you have 2 points, and then we have to put you on it or offer it to you. Does that make sense?
I think that makes perfect sense. And leading to the question of, do you think, Dr. Drescher, and do you see this from patients who come to you afterwards, that people are somewhat over-medicated in this group?
They can be. But which medication am I going to take away? You have
Mm.
benign prostatic hypertrophy and you're on Flomax, and then you have heart failure. If you're in heart failure, you're on 4 drugs now. Heart failure with reduced ejection fraction, you're automatically on 4 drugs. Okay, and then if you have a stent recent, you need to be on the aspirin, and you need to be on that, and then you need to be on the statin so you don't get the heart disease anymore. I mean, it's a difficult question to ask. I look at whether you need the drugs or not, and whether they're causing you any problems. So when I treat a patient, I don't look at the absolute number. I just look to see whether you really need the drugs. You know, are they treating something that's necessary? I'm going to tell you to have tremors and stiffness and shakes for your Parkinson's disease because I want to treat your heart disease, and I don't want to give you the medicine for your. You can't do that. You know, unfortunately, as we get older, we have multiple comorbid conditions and existing. And the thing is, the drugs and tendency go where they're supposed to go. They don't interfere with each other.
Yeah, but
So
risk-benefit ratio is
exactly it.
key to what you've said. Here's someone who reads the Journal of the American Medical Association, so that's good. They're informed and educated. They say that the JAMA Cardiology just reported in the New York Times yesterday that there's now considered greater risk above a systolic of 90. Can you comment on that?
Above a systolic of 90 or diastolic of 90?
Probably diastolic is what they meant to say, because I looked at that closer too, saying, that doesn't make sense. Yeah.
All right. We've always known that. That's how we first define. I mean, it's just, you know, sometimes doctors run out of things to study, so they study the same things over and over again.
Doctor, do you recommend making aortic valve replacements with artery or minimally invasive treatments versus open chest surgery for younger adult candidates in their 60s, for instance, where there's a history of developing aortic stenosis? Very specific question again.
All right. Well, let me tell you how we used to treat aortic stenosis. All right. When you're young, or any valve replacement, if you were under 65 years old, okay, say you're 50 and you need your aortic valve replaced, we would put in, they could put in a mechanical valve or a tissue valve. I'm talking in the pre-TAVR stage, before they had the percutaneous implantation. So you could put in, and because the kind of bioprosthetic valves we had, they weren't that good. They were pig valves, and they only lasted about 10 years. So if you open up somebody and did a valve replacement with a pig valve, 10 years later, you'd shrunk them and come up and need another surgery. So how many surgeries are you going to do to people throughout the years? You know, and then you have, you know, the younger women who are had mitral stenosis. We don't have too many in the States because we don't get rheumatic fever very much, but we get them here in Florida because we get people from, you know, Latin America or Haiti or whatever, never got treated for their strep throat. And so if someone's coming in and they're in their 30s, you know, you don't want to put in you definitely don't want to put in a bioprosthetic valve, because you know how many surgeries that patient's going to have. Well, this is really changing. And what's changed is, it's like in the aortic valve stenosis, the valves that they're making are much better. That's number one. Also, the size of the valve they can put in through the catheter is bigger than sewing one in. Okay, which means you get a bigger opening for the aortic valve, so it's less likely to have stenosis, come back with more stenosis. And the third thing we can do is, even if you have a problem with that valve and you get stenosis, you can put another one of those valves in that valve and open it up and put a new valve within that without surgery. So the way we're doing these things, so my advice to somebody that's certainly in their 50s even, is I wouldn't get a mechanical prosthesis, because they have a higher risk of clotting and stroke, etc. I would get a bioprosthesis. I've seen patients with 15 years now with the newer bioprosthesis, even surgically, that are doing fine now. They don't degenerate as much as those pig valves did.
Yeah. There's so many questions, and boy, we have to apologize ahead of time, because we only have we'll go a little bit over, because I think it's important for everyone's concerns. But some of the elderly people also ask, is there such a thing as my blood pressure being too low? And I think I know what you're going to say to that, which is why this cocktail of meds is so important to get just right and regulate it properly.
Okay. in general, we don't really care if the lower number, the diastolic, is low. Because people with a leaky aortic valve that leaks a lot, they can have the bottom pressure be 0. And they adapt to that. It's only when it's too high that you have risk of stroke, like above 90. And then even above 80,
So there's no such thing as having, poor side effects from a blood pressure dropping too low?
No, the bottom number.
Hmm.
Now, the systolic is when you start having symptoms. Okay. And the systolic pressure, okay, how you look at it is, what is too low? Now, some people have a pressure of 100 and they won't feel good, systolic. Some people have a pressure of 90 and they'll feel fine. So what we look at when we're giving medications, and I'm not talking, to lower pressure, we don't try to lower it down to 90 or 100. We just want to get it below 130. And we adjust the medicines accordingly. But what we really look at is 2 things. One, is it affecting your mentation? Is it making you dizzy? Is it making you not feel well? How you feel? 2, are your organs perfusing okay with the pressure that you have? Is your kidney function okay? Is there any other problems that are going on from that? And those are, so that we don't really look at an absolute number. I'll tell you, the heart failure patients with reduced ejection fraction that pump weekly, I sometimes have them with blood pressures of 85 because they need that lower pressure to make the blood go forward. And they tolerate it. Okay. On the other hand, other people at 85, they feel like they're going to pass out. So basically, it's a very individualized thing. There's no absolute number.
Yeah, which is why this is so tough to do, to try and address all people's concerns and questions, but it's so individual. But here's another specific question, and we're going to start wrapping up soon, but if you could get to this one. She's 65-year-old Black female who's been diagnosed with CHF, overweight, need of replacement, and unable to exercise due to severe joint pain in the knees. She's taking prescribed meds for CHF and worried that the condition will become worse, et cetera, et cetera. Big. So what she's talking about, she needs a knee replacement, but then she's got all these other issues.
Well, the problem with that is I'd have to know what kind of congestive heart failure, how bad it is. She's on all the medications that she's supposed to be on, because there's a lot of medications that you need to be. And it's very interesting. Like the ejection fraction is the number we use. It basically is the percentage of blood the left side of the heart pumps out with each beat. Okay, so say the blood, say you have 100 cc's of blood, or 150 cc's of blood in your heart, and you pump out 75 cc's with each beat, the ejection fraction would be 50%. A normal ejection fraction is above 53%. An ejection fraction of 40 to 52 is mild cardiomyopathy, which usually doesn't lead to congestive heart failure because there's still enough to pump everything out. When you get to 30 to 40, it's more severe and can lead to congestive heart failure. And if it's below 30, you almost always have some congestive heart failure. So basically, that's how we look at ejection fraction. So to assess somebody's risk for surgery, you'd have to look at what's causing heart failure. Some people have heart failure with normal ejection fractions because the heart is stiff. And that's called diastolic heart failure, or heart failure with preserved ejection fraction. So, but the good news for this lady is that knee surgery is a very low cardiac risk surgery. So the surgeries that are really high risk are when they open up your belly or they open up your chest. Because when they open up your chest, you don't breathe well, and this and that, and then it can contribute to other things, and then whatever. Or they open up your belly, you can't eat, and they have to put, weight, and they give you fluids and all this other stuff, and they give you too much fluids, and then you get malnourished, and then they have to give you TPN and all kinds of things. So the ones that are riskier are the ones where they go in the belly or the chest. The peripheral surgeries, for example, hip replacement or broken hips, when they put rods in there. These are people in 90 come in with that. With our
No,
disease.
absolutely. And all the joint replacements have become so much easier. But when you have other complicated,
Even with other issues,
yeah.
you'd have to be really bad for them not to fix it.
Yeah, yeah. Well, I think this is the perfect time to do the take-home message, which is, can you talk about, just to wrap this up tonight, the benefits of nutrition, exercise, and other lifestyle behaviors in reducing the risks of cardiovascular disease? That's, I think, the take-home message to send people home with tonight.
Okay, well, basically you have to stop smoking. Smoking is terrible. It causes heart attacks and strokes, causes lung cancer, causes emphysema. You definitely have to stop smoking. That's one thing you can do. We have at the University of Miami a smoking cessation program that you can enroll in, and it's been effective. Then the next thing is exercise. If you exercise moderately, even for a half hour, 3 times a week, that's been shown to decrease your risk of heart attacks. Okay, and as for diet, we don't really know that much about diet. The food pyramids that we had, that we think were a conspiracy of the cereal companies. None of those recommendations that we had were really based on any scientific data. There's only one diet that's been shown to decrease your risk of heart attack, and that's the Mediterranean diet. They actually did a study, and they were actually able to do that because, eat this stuff or that stuff, and they had a reduction in cardiac events. So I advise people to don't eat too many don't eat polyunsaturated fats at all. Don't eat too much saturated fat. If you have a problem with triglycerides or diabetes, don't eat starch or sugar, as little as possible. You eat a high protein diet in that case, and basically the Mediterranean diet has a lot of olive oil in it.
Right. So basically you're talking about low-fat proteins,
right,
lots of vegetables, good
right,
fruit, lower starches, less
exactly.
carbohydrates.
If you're going to eat if you like pasta, don't eat a big pasta like this all alone.
Right.
All right. That turns into sugar. What you do is you have a little bit of pasta like the Italians do for a primo piatto, a first plate.
That's right.
Okay. With a little bit of olive oil in it that slows the emptying of your stomach so the sugar doesn't go into your body. And then you have a nice plate of some protein and vegetables. And if you do that, you're going to do very well with your diet. That's the best kind of diet.
Thank you, Dr. Drescher. That's the perfect way to send everyone home tonight, because it's a positive message of you have control over your own life and you can make a difference. So we thank you so much for your informational presentation tonight. Thank all of you for participating and being so interactive with us. We ask you to visit umiamihealth.org to learn more about the cardiovascular program. Of course, make a virtual appointment or an in-person appointment to come into our clinics with our experts. And we hope that you've enjoyed tonight's talk and the words of wisdom from Dr. Drescher, who was a rock star tonight. Thank you all, and please make sure that you fill out the survey afterwards and give us some suggestions and whether you enjoyed it. Good night, Dr. Drescher. Good night to all of you.
Thank you so much, everybody, for attending. I hope you found it entertaining and informational.
Stay safe out there, everyone.